Jeremy Farrer is a global expert on infectious disease, and he's also director of the Wellcome Trust, which is one of the world's leading providers of non-governmental funding for biomedical research. And he's joining me now from London. Welcome to the program. Can I just start by asking you to react as a medical researcher to the obvious plea by the Chinese ambassador, who clearly feels, the country's under siege?
Yeah, I've got a lot of sympathy for what he's saying. I mean, we all know this started in the city of Wuhan in China, but this is not just a Chinese problem now. And actually, as Dr. Tedros said from WHO a couple of days ago, this is a time for solidarity, not a time for division. It is a time for us to work together. This could have started anywhere, in truth. When we faced the 2009 pandemic, the first case was probably there, in Mexico or the United States. So, we didn't work against each other then, and we can't work against each other now. So I have a lot of sympathy for what he was saying.
Okay, so sympathy for what he's saying, but what about the facts here? Because, look, as you know, there has been a huge confusion now. Chinese state media reported the death of the very young doctor, 34-year-old Dr. Wen Liang in Wuhan, and that was reported on state media, and it caused a huge amount of outpouring on Chinese social media. People were very, very, upset about that. So while they sort out the confusion about whether he's dead or alive, what might have happened had he not been censured by the Chinese authorities when he actually did go to them with this concern and with this evidence in December?
Yeah, I don't know. I don't know him personally, but all my thoughts go out to him and his family, and I desperately hope he is still alive. A number of doctors and nurses in China, in Wuhan itself, have died. We know that. I lost a lot of friends during SARS in 2002 and 2003, and the bravery of these doctors and nurses is extraordinary. It's the same with Ebola in the Democratic Republic of Congo. It's very difficult to describe what it's like to be in the middle of that. I don't know the details of when Dr. Li went to the Chinese authorities. I don't know what he went there saying. I knew about this on about the 29th or 30th of December, about the same time that WHO knew about this. Since then, I have to say that the sharing of information has actually been good or very good, and I've not been aware of a cover-up that's gone on that's sometimes being accused of. I think it's really important to put into context. When you're a doctor or nurse or public health person working in this scenario, it's chaos. Wuhan at the moment is in lockdown. The city deserves all our support. Public transport is closed. Workplaces are closed. The hospitals are absolutely overwhelmed with patients. They're overwhelmed because they're in the middle of the influenza season as well. And it's chaos. And on a personal level, it's terrifying. You're dealing with an infection that none of us have seen before. Your patients, your community, the people you know, probably friends of yours, are coming into hospital with moderate and very severe disease, and some of them are dying. In fact, many of them are dying. That's a really frightening scenario to be in the middle of. And I think undoubtedly you could look back, and now we can say, maybe the authorities in China could have handled it better. It's always true when you look back. I think the time, though, is really to look forward and think, what's happening in China? What can we learn from that in North America, Europe, Africa? Africa is a real concern for me just because of the fragile health systems that it's going on.
Well, let me ask you, because I clearly want to ask you about Africa, because that is a big concern, as you've just said. But in terms of we need to all look to the future and now try to get in front of this spread, how can you actually, if you don't know all the data and the rates of infection, how does one actually get a handle on it? What do you need to know in order to be able to get a handle on it?
Yeah, well, we do know a lot more than we did 2 weeks ago. We know a lot more than we did a month ago. And that information is not encouraging in some ways. The things you need to know, in no particular order, you need to know how infectious this is and who is passing it from one person to another. Is it children? Is it the elderly? Is it people in schools and workplaces? How long are they infectious for? If I was to catch this today, would I be infectious tomorrow morning? Would it be in 5 days' time? And would I be infectious for another week or 10 days. That's really critical information to know. We need to know, if I were infected today, how many people that I met would I give it to? Is it 1? Is it 2? Is it 4? Because that tells us a lot about the way the epidemic is spreading. Okay. On the clinical side, is it asymptomatic in some people? Will some people be infected and have absolutely no symptoms? And if they do, will they be infectious during that time? And then those who have got symptoms, what symptoms do they have? Is it different to influenza, or does it look very similar? Is it a sore throat, a headache, muscle pains, cough? And if so, which patients will go on to develop more severe disease? And what can we do to treat those with a severe disease to try and reduce the number of people that are dying?
Do you have any answers? More things. Do you have any answers to all those questions?
I do. What happens in these scenarios is you start to get a picture of what's happening, and you have to make decisions, big public health decisions, big clinical decisions, based on relative uncertainty. And as the weeks go on, this week compared to last week, compared to a month ago, we're starting to get a better picture. So, for instance, the figure that I mentioned, if I had coronavirus today, how many people would I give it to? I think increasingly we think that's about between 2, 2.5, 3 people. Let's say it's 3. We think the infectious period probably lasts between 2 and maybe up to 10, maybe 9 or 10 days. That's really critical information. Really important, and this may be a clinical bias that we haven't been reporting it. They've not been picked up, but we've not seen many children. We've not seen many people under the age of 20. That's a really important finding. And then the finding this week, which is completely unexpected, at least to me, that we had a child born and within 30 hours was known to be infected. When did that child get infected? When did that baby get infected? Was it during birth, or was it earlier, prior to birth? And again, as we learnt with Zika, the impact on gestation and pregnant women is a really important question which we don't have answers today. But we are getting some answers. We know more or less more about the severity. We know more about the infectious period. And we do have a better handle on this famous figure R0, which is the number of people that I would pass it to if I was infected today.
Well, you've just said, I think you said, let's say it's 3, right? That R0 figure, for the sake of kind of argument, 2, 2.5 to 3. But look, you know, the WHO itself has said, today, we need to bring this virus out into the light so we can attack it properly. So you're saying that we have some more information. They're saying we need even more information. And you just mentioned Africa. I want to ask you how Africa, what you expect might happen there and how it might deal with it. I mean, we're hearing here, even in the United States, reporters, if you look at the newspapers, are talking about people who are coming back from China. You know, some of them are coming to prescribed airports, but then a lot of them are on their own. Some of them are going to military bases to be quarantined. A lot of them are just being told, go home, quarantine yourself. If that's happening here in the most developed health system in the world, what happens in what you rightly say, you know, a place at risk with a not so developed public health system, like in Africa? What are the particular challenges there?
Well, over the last 20-odd years, there's been a dramatic increase in the trade and travel routes between Asia, not just China, but actually across the whole region and Africa. And that, therefore, poses a huge risk that wasn't there maybe 10 or 20 years ago, just because of the connectivity now between Asia and Africa. We've done some lovely mapping along with colleagues in the UK and the US, just looking at where the cities are most connected to China and also to Asia. And that's essentially, it's the airport hubs. It's the airport hubs of the Middle East, and it's the airport hubs of Kenya, of Ethiopia, of Nigeria, South Africa. It's those cities which are most connected by travel to China. But you're absolutely right. The healthcare systems in many parts of sub-Saharan Africa, but it's not just sub-Saharan Africa, it's also true in Central and South America. Venezuela, for instance, is really going through a crisis in terms of healthcare at the moment, and the implications of this, if it were to arrive in Venezuela, would be devastating. I would say, though, and this is really important, the changes in Africa in the last 5 years, the setting up, which China has played a critical role in, the setting up of the African Centre Disease Control, very much modelled in some ways on the fantastic American CDC, is there in a way that was just not structured there 5 years ago. And also in Nigeria, just call out Dr. Chikwe and the Nigerian CDC. Just, that sort of leadership perhaps was not so evident 5 years ago, and it's certainly there today. But you're absolutely right. They're very fragile health systems. DRC has not got rid of Ebola yet. There's malaria, of course, and tuberculosis and HIV, and we have no idea how this virus will go in people who are HIV positive.
So just quickly, what about the idea of a vaccine? I mean, there again seems to be confusion in the public space over that. Yesterday, we reported what seemed to be a breakthrough, that a British doctor, medical researcher at Imperial College, had figured out a way to shorten the time to from a couple of years to 14 days to get a vaccine. Now we're hearing that maybe that's not correct and that it might take even longer. What do you know about this story? And of course, that puts more panic in the population as well.
Yeah, no, you're right. And I know Robin Shattuck very well at Imperial. He's a superb vaccinologist. But I think Robin would be the first to say it's really important to be really clear about this. We can shorten the time to vaccine development, we believe, but we can't shorten it completely. I believe we will be in phase 1 trials. That's the first time it goes into man through the National Institutes of Health in the United States, and here through CEPI in the UK. We will be there in human trials, I believe, in March or beginning of April. But that's the first step. That's the step to show that it's safe and it produces an immune response, which we hope will protect people about coronavirus.
Right.
We then have to go through large-scale trials, and we then have to manufacture it. And we don't just have to manufacture it for America or Europe, we have to manufacture it for Africa as well. And realistically, that's not until the end of the year, into next year, if everything goes well. And just remind people, we don't have a vaccine for a related virus called the common cold. So this isn't trivial to do. Next year, we may have a vaccine for public health purposes. I doubt if we'll have one this year.
Well, it's very, very good to be clear about this and the complexities of it. I just wanted to ask you to elaborate on the sort of knock-on effects. As we know, there are thousands of patients being quarantined in ships. I mean, there are two cruise ships off Japan and Hong Kong. They have to stay in their room, food being brought to them. Sometimes, it's late and all the rest of it, a lot of hardship. But even on a more sort of emergency level, in Wuhan, in the areas around there in China near Wuhan, there's this really heart-rending testimony from a lady who can't get her daughter to take leukemia treatment. She's standing at a checkpoint and they're barring any movement because of the coronavirus, and yet the other disease can't be treated either. Here, just take a listen.
I'm obviously very upset because you're examining and treating patients with coronavirus, but our illness also needs to be examined by a doctor. Right now is a special time. The small hospitals in our area can't treat her. We just want to go to a big hospital to get her seen by a doctor.
I mean, as you said, Sir Jeremy, the level of chaos and fear and panic on this level and all these other major diseases, it must be just terrible in the hot zone.
It is, and I mean, that's heart-wrenching to listen to that, and I think that really brings it home what this means, what a lockdown of a city really means. It is about coronavirus, but it's also about those people who are needing care. It's about safe childbirth. It's about people being treated for cancer, as that lady's mother was, and this puts enormous strains on healthcare systems, and China is actually pretty well developed in its healthcare system. The truth is, I think every country would be really challenged with dealing with anything on the scale of what we're witnessing in Wuhan. Africa, of course, may be disproportionately affected, and we must not leave them behind. As I say, this is a time for solidarity. But the truth is, Western Europe, Japan, North America, Canada, United States, all of the countries will really struggle, particularly if this comes in the Northern Hemisphere during the influenza season, when hospitals are under such additional pressure. There isn't very much surge capacity in any country in the world, even the most developed. And the critical things we need to do now, whilst North America, Europe, Africa has not yet gone like China, we hope we can avoid that. The decisions we're making today, we hope will mitigate the worst of this epidemic. But we've got to put in place those plans. We don't need to panic. There's no panic achieves nothing. There's no need to scare people, but we do quietly need to put in place the surge capacity in the United States, in Europe, in Africa, in Australia, and around the world that we might have to use, and we just have to accept if we make the right decisions and prevent this epidemic taking off, they may not be used, but they're absolutely critical to plan for today. Same with the vaccine. We may not have a vaccine for a year, but it'll be a year or more from whenever we start, and we've got to start that today, and the world's got to come together, as it has done, and make sure we put all the resources. Money cannot be a limiting factor here, and we've got to get this done, and we've got to do the planning of the health system to think through the consequences of facing a Wuhan-like system, a Wuhan-like event in New York or London or Paris or Berlin.
Well, I hope the experts are listening to that warning and to that advice. Sir Jeremy Farrar, thank you very much indeed from the Wellcome Trust for joining us.